the SAPT tool. And we're going to start recording this too for people that can't make it today. So if some of your colleagues weren't able to make it, they will be able to see this in a recorded session. And we're going to post that probably on the LSF YouTube site, and I will give you some information on that afterwards. But the PowerPoint's going to be placed on a ROSC landing page on the LSF website. So we're going to be able to send that to you in a follow-up. Again, I wanted to thank everyone for joining us today and being part of this talk about recovery and the SAPT implementation project. My name is Brian Mingle. I've been a quality improvement specialist at LSF for several years, and recently I was appointed to the ROSC specialist. And Nancy Rice is in the room with me. She is the co-pilot of today's training, and she's also a ROSC subject matter expert, and she's available for TA as we go through this process this year. She and I are both in long-term recovery, and so this topic is a special. We have a passion about it, and I see a lot of peers on the call today, and I see their supervisors and directors and people that have been a part of this recovery movement in Florida for a long time. So I just want to make sure that I express the gratitude for all the work that you're doing in this realm, and we appreciate it. And of course, there's always more work to do, and we're going to try to give you a lot of, not too much, but some information so we can strengthen this recovery power out there in the community, and make it a real force for helping people meet their full potential. So when we have questions, if you have them in your head as we go through the slides, pop them into the chat, and then that's a good way to remember it, because if you're like me, you may forget the question after 30 or 40 minutes expire, and we can go back and then answer those questions at the end of the session. Okay, so we're going to just go right in. And I like to talk about the big picture in the beginning, like why are we here? How do we get here today? And to start off with, we all want to recognize, I know I do, that recovery is possible, that despite many difficult and life-changing experiences, people with mental health and substance use conditions do recover. And when we work together, like we are today, providers in the communities, we can shift from a system of acute care management to a system focused on recovery and wellness. That's the overarching goal of a ROSC. It's a framework. It's not a project officially, it's not an initiative. It is an ongoing cultural shift, because for years we're operating in an acute care management system, and it's slowly changing, and we've made lots of strides, but there's more work to do. So today's objectives are, we're going to understand the goals of recovery-oriented system of care. We're going to do a little ROSC primer, not too long because there's a lot to it, and many of you know what ROSC is. You've been involved in this for a long time. There is a history to it that we're going to recap really soon. We're going to review practical ways to transform. We're going to learn mostly today, we're going to learn what the self-assessment planning tool is and the recovery self-assessment surveys. There are 3 RSAs, and they are being used throughout the nation and in Florida for the last few years to support ROSC system improvements. And then we're going to give some guidance for implementing the SAPT and the RSA surveys. A brief history, like we talked about earlier. This is not just an LSF project or a state of Florida one and done. It's a national recovery movement, and it's a priority of effort among those in the behavioral health fields. Many of you may remember the ROSC summits in 2015 in your county. Hopefully, if you were working at your agency, you knew about it and you got to show up. And those were held for over a period of 2 to 3 years. We held them and invited the stakeholders, partnerships. It wasn't just agencies, because ROSC is a community gathering, recovery capital type event. We want partnerships. So if you remember those, that's related to what we're talking about today. And SAMHSA supports the ROSC framework, and they assist with a lot of resource materials to help transform the systems of care throughout the nation. Here's a key milestone in the ROSC history. In 2003, George W. Bush, who was president, formed a commission called the Freedom Commission. So mental health was starting to get some more attention. It was elevated because the report found that the system was fragmented and in disarray, and it was leading to unnecessary and costly disability, homelessness, and school failures, incarceration, all of the things that we're working on today through the jails, prisons, schools, children, adolescents. It was catching people's attention then, and the reports was a big report, really thick, but the main fundamental finding was that the service delivery needed to be based on a vision of recovery in order to help people actually improve their lives. And a lot of that's being done. We've seen huge strides in the last 2 years in RCO development. We're going to talk about that, recovery community organizations that are sprouting up all over Florida, especially in the Northeast. Let's do a little history on the SAPT tool. I call it, it's good to just refer to it as the SAPT, but it stands for the Self-Assessment Planning Tool. There's a little screenshot of it. It has 3 domains with 50 questions. The SAPT was developed right here at USF in Florida by faculty, subject matter experts, also known as epidemiologists. And we invited people with lived experience in mental illness and substance use disorder recovery. And they got together and they developed this tool, which is a fact-finding tool about perceptions of recovery at agencies, behavioral health agencies, or any organization. But mostly it's designed for treatment. This particular tool is, and it has 4 ratings. It's on a Likert scale. It does not have a don't know or an NA. The NA and don't knows are on the RSA surveys. And they did that for a reason. And we'll talk about that. I can give specific guidance to the clubhouses and some other non-traditional organizations in our system of care that don't have treatment. So when you get down to the treatment questions, that could throw you off. And so I'm going to help guide you guys when it gets to that with some further communication. And the reason they came up with this, because under the Florida handbook, Medicaid handbook, it lists all the services, but there was not a quality assurance system in place to determine if people were really achieving their life goals, which is recovery. Recovery isn't just stop drinking and stop doing the drugs that you were doing. It involves a lot of other social determinants of health. And so that's what a vision of recovery is about, is are we helping people with their whole health, because if you don't have a house over your head or finding meaning in your life, then the chances of you solving your primary disorder, whether it's substance use or mental health or both, is less. So it's sort of wrapping around. ROSC is a wraparound approach. Going back to the ROSC summits that I mentioned earlier, there were 5 priorities that came about from that. There was a lot of cafe conversations in the rooms. We had a lot of breakout rooms. And what the community told us was that we needed to improve our collaborative service relationships, cross-system partnerships. And that's what we're doing today in a way. We're having a lot of interagencies get together. We're starting a process where we're going to have monthly calls. I'm going to give you some tips on how to reach out to, you're doing a lot of this already, like reaching out with nonprofits in your community that can help people find a passion or replace what they were doing in an unhealthy way with healthy ways. And so partnerships are very big, community integration, community health and wellness, and of course, peer-based recovery support. A lot of the communities told us, based on what they knew 5 years ago from peers helping them, that they wanted more of that. And so we are really strengthening the workforce with peer specialists. You guys are doing a great job learning about peer concepts, employing peers, and giving them volunteer hours also, so they can get their hours for peer certification. And so I just really appreciate that. So all of this is a shared vision, and the MEs, of course, and DCF we're the facilitators and the leaders of this, and we want to provide as much TA as possible. We have a lot of other stakeholders who are providing TA, such as Faces and Voices of Recovery. They're a national group, and we can link you to their trainings. It's available for our providers too, not just the RCOs. So they have some amazing trainings on recovery capital, how the peers can work with non-traditional plans, service plans that are based on life goals. And so I'll be communicating more of that with you in the next year. Been doing that quite a bit actually, and you guys, I'm sure you get the Brian Mingle emails. There's so much trainings out there now that I just want to assure you there's more coming too, because with our turnover in the system, with people coming and going, being hired new, we always need to provide that and make it sustainable. And we have made some sustainable improvements lately that I'm going to announce on this call. The primary goals of a ROSC, again, the ROSC primer is we want to prevent the development of behavioral health conditions. That's prevention. Prevention and intervention are key to a successful ROSC. We want to reduce the harm caused by behavioral health conditions, help individuals and families sustain their wellness, and promote a good quality of life and wellness for all. And some specific strategies to promote in a ROSC are assertive outreach and engagement. And these come about through peer support groups, even before treatment. If we can get people in through outreach to come in and process their feelings, their hopes and dreams, and that may help them stay out of residential and some more expensive modalities. A lot of your agencies that I see on today are going into jails and prisons and linking, meeting people, building rapport, and helping people before they're released, so they'll know that there's support out in the community for them. Offering peer mentors as soon as a contact is initiated. A lot of our agencies are coming up with peer warm lines and numbers to call, and doing a real good job of marketing that. RCOs are jumping right into the system of care as non-traditional providers. And want to stress today, one of the takeaways I hope you get is that if you don't know of an RCO in a county near you or in your county, please get to know them so you can put that on the discharge plan or link people to them when they're in front of you. There's a lot of agencies that are peer driven that are on the call today, whether it's NAMI Hernando has peers. They're doing a lot of great work in the training arena and in peer support. And one thing I meant to say earlier in the prevention intervention is care coordination too. Care coordination has been a big part of the ROSC movement because that's following people when they leave your facility and just showing them that you care. And the care coordination legislation was set up and actually named recovery-oriented system of care in that legislation several years ago in Florida. Telehealth is a big component of ROSC, especially in the rural settings. And those warm lines come into play a lot. We found out through the pandemic that there's no wrong door. I have actually given out warm lines in one part of our region and asked people in another county far away, not adjacent, that they could call that peer line too, because telehealth it doesn't have a boundary, it doesn't have a county line. So, and when you're a part of the state network, there really is no wrong door. There is an expectation that the peer you hire can help someone in another county. There's no county criteria. And doing this, you build strong linkages between levels of care, but it does take more effort to know where to refer people to, and there's a lot of locators to find treatment, on the SAMHSA website. And if anyone ever has questions about that, please reach out to me and I can help you with some resources. The rest of the strategies are pretty clear cut. We can connect with people before their appointments. Screening and early intervention and primary care is also part of ROSC. A lot of our big agencies have primary care on their campuses. Let's see. And another way to look at ROSC is through the building blocks of ROSC. Number one is we're doing that now. We're developing a shared vision and we're strengthening our collaboration. We're focusing on prevention and early intervention through the promotion of population and community health. That's the social determinants we're talking about. We hope that everyone knows there's a lot of housing subject matter experts in your region, in your county, and LSF has a housing department that we can help. There's COCs in most of the counties. because we want to address more than just treatment, but try to help point people to other areas that would improve their life. And number three is just getting executive buy-in through the fiscal policies and administrative alignment. And that goes all the way up from the leaderships at your agencies to the state legislature. They're involved in the building of a successful ROSC. We're aligning treatment with a recovery-oriented system of care. We're fully integrating peers and other recovery support services. We're developing a mobilized, activated recovery community, and that's just another way of saying RCOs, the recovery community organizations that are popping up all over Florida. As I said earlier, we have 7 in the Northeast LSF region, and they've been around for a couple of years now, and a lot of startup money for each was given. Not a lot, a little, and now they're billing for services, for recovery support services, and actually making quite an impact with their passion, and just their have boards of recovery champions, and the peers that are working there are just really passionate about their work, and especially in Narcan training and Narcan distribution. We're seeing thousands of kits distributed in the areas of the RCOs. And Nancy and I are part of integrating recovery-oriented performance improvement and evaluation. Some of you on here have heard about a ROM or experienced a recovery-oriented monitoring visit that Nancy and I and Desiree Manning, Desiree Manning and Carol William Hayes are the DCF recovery quality improvement specialists. And they work with us too as a team with Nancy and I, and we support you guys with what we find out when we look at a chart and we talk to the individual in the chart. We're finding out about the experience, what some of the gaps are. We're finding really good information. We're also finding areas, opportunities to improve. And we're sharing that with your agency in a way that's attached to trainings and support and some ideas. And so that's quality improvement. And this is what we're doing today is part of that. And now we're going to get into the SAPT part of it, I think, after this slide, which shows what the outcomes are of a strong peer workforce. That builds hope and resilience. It gives people that are being served an active role in their treatment. It's very person-centered. It gives them literacy in terms that they can make good decisions based on good information. Helps with their satisfaction with services, keeps them engaged, connects them to their community, helps them handle stress and improves their quality of life. And again, it adds to their practical outcomes in housing, job search, and finances. Now, more about the self-assessment planning tool, the SAPT tool. It's 50 questions, is organized under 3 domains. This tool is geared for executives, clinical directors, and a sampling of direct care staff. This is not the tool to send to as many people as you can. It's very targeted. It has questions related to administration, treatment, and the community integration. And again, it's under a 4-point rating scale. Like I said earlier, respondents should come from administrative leadership, clinical directors, select clinical staff, non-clinical, a behavioral health tech in the CSU, for example, and a peer specialist would be examples. You're going to examine scores for each domain. Let me tell you a little bit about that process. That process is that we're going to give you links to these surveys next week. Then your ROSC committee, the ROSC committee that you form, is going to develop a process plan. And in that process, you're going to figure out how to distribute the surveys to your staff and to the people you serve. There's going to be links, like I said, links, and the links go to a database that LSF is going to pull from. We're going to generate reports. We're going to keep the window open for a month from October 1st through November 3rd for these surveys. And we're going to close it down, and then we're going to get to work actually developing reports on what the data shows. And the key thing is to look for discrepancies between the perception of recovery orientation from the people you serve and what the staff thinks and it's all anonymous. It's very good data. I just want to say again that I don't think I said this earlier, is that in 2019, there were 9 providers in our network that did this. They did the very same things I'm talking about, and they learned a lot. There's actually been some really good action steps from several of our providers, whether it's new employee orientation trainings based on recovery practices, or one provider created focus groups, and they formed an advisory board of people that were served by your agency so they could get feedback, because truly there's no better feedback and quality improvement than the information that comes to you than from the people you serve, right? Because that's how you can get a real feel for what's working well and what people would like to have seen that would have helped them. And there'll be more than one thing, because treatment should be individualized. And I just want to thank the ROSC transformation committees at your agencies. A lot of you, almost all that are on here today, I'm sure, sent the spreadsheet with the names of the people on this committee. And don't want it to be a heavy lift for your agency, that you've got a lot going on and you guys are spending a lot of time and hours doing the real work. But if you can fit this into your quality improvement process, that's what we're hoping to do. And that's why we have quality improvement involved in this journey. And we're trying to support you as much as we can with a database. And we're gonna, like I said, we're gonna send you the reports in early next year. Talk about more what that looks like. And when you get these reports, it will inform your quality improvement strategies. It will provide practical suggestions, and it'll also have some resources. And so we'll talk more about those resources in a minute. On this slide, this is a hyperlink where my cursor is. It actually goes to this self-assessment planning tool manual. And I do encourage the ROSC committee, several members of it, if not all, to read this manual, because it has a lot of good tips. It even has a template for an email to send out to staff. And because you want to communicate to the staff why they're being asked these questions, and so they'll know about the big picture. You guys are on here today, and each of you are emissaries and communicators of what we're doing. Because if I saw something in my email box and I didn't know, and there was no explanation about it, I would easily overlook it and not do it. So you know how that is. It's a human thing to do. Again, I'm going to look closer at the RSA surveys, because these are the surveys that actually show me what I think is the best information. Like, there's links here so you could see what the questions are, but we're going to send you real links that will be available connected to the database. But there's 3 RSAs. One is for the adult person in recovery. 2 is for the children and adolescents. It's slightly different because some of the questions are geared toward adults, and then we didn't want to ask that. And then we have number 3, which is the provider direct care staff. And you're asked to send all these surveys right here to as many people as you can get. The more respondents, the better. Again, if you're a small agency, we don't expect you to have a whole lot. You just want to try to get a good sampling. And again, they're all going to gauge the degree to which programs implement recovery-oriented practices. And just to be more specific, along with the links, we're going to send you QR codes. And so there'll be separate documents attached to the email, a QR code for this number 1 survey, 2, and 3. And then in the links for these, they'll be in English and Spanish. Wish we had Haitian, but we don't. But if you need any help in that area, that's going to be very specific, and I can help. I'm here to help with that if you need any assistance on that, linking you up to somebody that can help. But we found in some other survey projects and the needs assessment that if you put a QR code up in part of your facilities where clients walk by, and as long as you let them know about it, they can put their camera up to it before they get in their car, and they can actually fill out that survey before they start driving. And however, we offer the QR codes because we found it's one good way to get people to answer. They can do it on their phone. But we don't give the flyers to you. We kind of you can make a little flyer, put it on a PDF, QR code with a heading on it. However you guys want to do that. Again, this kind of just summarizes what we've talked about. You guys are going to administer the SAPT and the RSA surveys at the same time. And again, the dates are October 1st through January 3rd. This is going to give you performance data from the perspective of the staff and the people served. And then the ROSC committee that you form will hold meetings. You'll identify areas where there are discrepancies between the perspectives. This will help you pull down some 1 or 2 or 3, however many you want to do. There's no requirement that for how much action steps you want to write the first year or the second. But you want to kind of like look at what you think is the most pressing and the most important. And also it goes with capacity, what your staff can work on. Totally understand how projects work like that. Going to look closer at the timeline here, just to repeat and review what we've talked about. Next week, which is mid-September, I'm going to email you the links to the SAPT and the RSA person served, the family advocate, and the provider survey, which I left off of this slide. But you'll get all 3 links and their QR codes too. On October 3rd, we hope that's enough time for you to get it set up to distribute to the staff, to email out, and to set it up for the people you serve. We're going to open the links on October 3rd. We're going to close them on November 1st. And then our staff through the holidays is going to work on generating reports to all the network service providers that are participating. And just so you'll know, the first year, there are several providers that aren't participating because they're prevention or they're trainers. They don't have services that are client specific. And then some we're just giving them a year. They can jump in next year because this is an ongoing yearly project. I will call it a project, it's a rollout because it's ongoing. And so you can update your plans next year. You can pick another action step based on the results from next year's SAPT and RSA deployment, call it deployment. And so through February and June 30th, we're hoping that you guys have drafted some action plans. I'm going to send out, along with the email next week, I'm going to attach a template or a action plan. It's a strength-based opportunity action plan template. You don't have to use it, but if you'd like to, you're welcome to. And then when you guys do have a draft of an action plan created, if you could email that to me and copy Nancy Rice, nancy.rice, that would be so much appreciated. And so again, every year we're going to be doing this, and we're going to make it fun, as fun as we can, and it's going to help people in their recovery in their communities. And that's the big picture. So I hope you guys are excited to go on this journey with us, with Nancy and I. And now we're going to entertain some questions. So if anyone put questions in the chat, this is where I'm going to look at it. And I'm also going to take people off of mute. So you can pop up, raise your hand. I'm going to look at the chat now. I don't have it up. There we go. Does anyone have any questions? Does everyone, you can take yourself off mute. How many surveys do you suggest collecting? Tina, like I said earlier, I think your sample size, like how many people do you serve? And that kind of then I could give you an estimate. You could do 50%, you could do 30. It's the more the better though, Tina.
Thanks, Brian.
Yeah.
Hey, Brian, it's Rico.
Hey, Rico.
So I noticed that the release of the adolescent surveys, have those been done in the past?
They have not. When we did this in 2019, that's a good question. We did not have them. I did not know about them. And then children's agencies were exempted from the pilot in 2019, even at Gateway. And you work at Gateway, which is, I'm glad you spoke up, Rico. If you'd like to share about you did some innovative collection methods because you had a lot of residential clients that responded, and you had little, I'll let you talk about it. You had little kiosk or laptop set up in the community for people to answer the RSAs. But we will have it for children now. We have adolescents and children. There's a separate survey.
Well, I'm excited about that because that now includes our adolescent units.
Yep, exactly.
knowing that this allows the participants to have a voice about their own recovery, and you're able to see the stark difference sometimes, and sometimes it's really a great collaboration between the two, where the individual providing the service versus the individual receiving the service, how that actually comes out once a survey is done. And it really gives a roadmap of what areas a provider can work on. It really gave us some great tools to utilize and move towards more of a ROSC framework, as you talked about, it being a framework and not necessarily a direct provider procedural. It's more of a framework where I know many of people that are on here know that recovery happens in the community. It doesn't happen inside of a treatment center or a facility. It happens in the community. So in getting that individual connected into community services or natural support, so they are continued to be supported.
Thank you. That's so true. And one thing I want to forget, you guys asked for it 3 years ago, and they added it for this survey. Is we're going to have a drop down for the providers for what category of provider staff they are, whether they're a care coordinator, a peer specialist, administrator. We're also going to have the program drop down, so you'll be able to know, instead of getting a report just under Gateway and you don't know, we're going to be able to drill down into the program they're talking about or that they were enrolled in, whether it's residential. CSUs, we're going to have a selection for that. So we may ask, I think it would be a good idea for you guys to get familiar with the survey itself, what it looks like go through and answer one yourself, and then give you, if you're talking to your client in front of them, you'll be able to say, in case they don't know they're in a care coordination program or in residential, because they are going to be asked to identify which program they're talking about. So we're hoping that people can identify what program they're in, but if you could give them any help, any background, if you get that opportunity, and some of the things may be emailed out if you're doing telehealth, but any type of guidance that you can give to the clients would probably be helpful.
Brian, now, can you talk a little bit more about how often LSF is going to put this out? Is it only annual?
It's going to be annual, which some providers we thought that was a lot. Maybe it should be every other year, but the guidance document asked us to do it every year. And so, yeah, and that's actually a good thing, because people's perceptions and the agency changes. The agency changes if you're making some of these. If you make one added improvement a year, you can then see how a difference it's making in what you hear back from people and your staff. So if the plan is to do this every year. Nancy and I are still kind of developing what the support and the oversight looks like for that. It's not going to be micromanaged, it's just going to be that because the provider network is given a lot of autonomy and independence to be able, and trust, to be able to see what's needed and what you can actually look at in terms of your capacity and your workforce. So as long as I'm working in this realm, there won't be any unreasonable demands, because I totally understand what it's like to work in direct care at a state agency. But I've also seen the progress that you guys have made through your work, through the recovery practices that you're doing. And it's just, hopefully it's going to be a really honest process here, and very transparent. And when you're having challenges and barriers, to be able to speak up and talk about that. And that leads to something I want to add. We're going to organize monthly TA calls. You don't have to be on them. If anyone from the committee, at least someone from the ROSC committee at your agency, could be on, and then talk about what we talked about, or at your meetings, that I'm sure you're going to have meetings at least once a month. And but everyone is welcome that is participating in the ROSC rollout or the SAPT rollout. And so Gateway and anyone else on here from 2019, I think Jennifer, I don't want to call out names, but I just did. SMA was a active participant in the the rollout in 2019, and they came up with a very excellent new employee orientation training. And again, that was 3 years ago, and so maybe you'll learn some new information. And I do want to announce that there's a resource page here that I don't know where it is. There it is. Skipped over this. We have created a LSF Health Systems ROSC page, and this is going live. I think it actually went live today. And if you clicked on here, this PowerPoint will be on this page. So if you kind of favorite this URL right here, it will be a great treasure chest of resources for you. Right now, it has 7 recovery management practice training modules that the Florida Certification Board created recently. And they will align really well with a lot of the action steps you're probably going to see, because they're going over a lot of real practical ideas to strengthen recovery at your agency and in the community. We've got the manual link on here, the one I mentioned earlier, and the RSA surveys. And then we have the DCF guidance document that this all goes back to. And there's a segment in the guidance document that talks about the SAPT and what the requirements are. This truly is like the first time we've ever had any, requirements in it, but because we've done a lot of supportive TA and a lot of education about all of this up until now. The expectation, as we all knew, that it would be in the state contracts. And so that's just because we don't want it to die away. You know how that can happen in our system of care. We can talk about things and then it can fade away, and the traditional acute care system stays the way it is. And we really are changing the system. We're not getting away from traditional, but we're just adding recovery orientations and in a way that is transforming the whole system, and is transforming recovery, and it's improvements, and that's what we're doing. Like Nancy said, you're gonna receive an email from LSF from me, either probably late this week or maybe early next week, and we're gonna attach the PowerPoint to it. But you're also gonna be able to go to the PowerPoint on the LSF Health Systems ROSC page. Rico, you've got your hand up. Stop talking.
Brian, can you talk, didn't the LSF survey questions change and somewhat mirror what's happening with the RSA questions?
The consumer is now known as the CPSS, the Consumer Satisfaction Survey, or person-centered. It did change, and it does, it actually reflects a lot of the RSA person served. And I think and just know that survey is for all the agencies too, and it's a requirement from the community block grant. There were a lot of the ROSC champions at the MEs, the ROSC leads, that said, why can't we use the RSAs for the consumer? Why are there 2 separate surveys? And I totally agree with that question, but we never got approval to use one, and it does seem duplicative. Is that what you're asking, Rico, or pointing out? And I'm right there with you, because to me that is a little bit duplicative.
So, we like the RSA questions so much that we actually had created a Survey Monkey.
Mm-hmm.
And so, after that pilot had basically shut down with LSF and DCF doing the data mining, we created the Survey Monkey in order to continue that whole process of really looking at what was going on, not only with the participants, but also the individuals that were providing the services. And we had moved towards being able to actually do it more of an exit survey. So we could have that really rich data instead of just that one-time snap. Because if anyone's in a treatment arena, that the milieu can get shaken up by 1 or 2 people, and it could shift or get better or worse depending on the time of the year. And
Sure.
We really like looking at the consistency of almost like an exit interview through treatment. So they had that. So we really had those full questions of what was going on within the ROSC. We really like those.
That's awesome. So are you gonna, now that you have another collection archive for it, are you gonna continue both, or are you gonna just transfer, shift over to the Cognito site? Because these are gonna be Cognito forms, Cognito links. And it seems for your agency, at least, it's gonna be a continuation of doing something you were already doing. And you're gonna be very important if you can attend some of the TA monthly meetings, because what we're seeing is that it works so well, just like in recovery, to have a mentor or a buddy system where you can guide people along where you've already gone, share some success stories. So I appreciate you speaking up today, and I look forward to you continuing, Rico, if you have time to pop in. Very valuable. Thank you. Does anyone have any questions that this is totally new to? You've never heard of a SAPT tool or the RSA surveys? It's probably very, very possible. Don't want to assume that this is new and old information to everybody. We're here to start from scratch, and just that's what I tried to make this PowerPoint about, for the people that are new to the ROSC movement. And glad to see a lot of Park Place people on here. They're new to our network, and they're doing great work down in Circuit 5 area, the counties down there. A lot of peer programs. So excited to be working with you guys. Anybody have any questions? If not, I want to be respectful of everyone's time, and really appreciate your attendance today. Will the survey be emailed so we could take one ourselves? Yes, and I would I encourage you to take one before nothing will be live until October 1st. So a good way to get familiar with the surveys that I'm going to send the links out, like I said, soon, in the next few days. Take the survey yourself, and that way you'll get familiar with it. And what I'm asking, I'm going to send these surveys in the PowerPoint to the ROSC committee liaison that was sent to me. And I ask those people to distribute it down to the members of the committee. Okay, I'm gonna do it that way. Yeah. Yes, Citrus County live stream. It is definitely something you should be doing. Trying to remember who your ROSC committee chairman is. I think it's Eva and Jill. I don't know, but whoever is the ROSC committee chairman will be sending this to you, because yeah, for the big agencies like Livestream, you're not in just one county, you have programs everywhere. But it's up to your ROSC committee to decide if they want to go into all their counties the first year. They may just focus on Sumter or and not Citrus. So there you go, Megan. I was trying to remember your name. I'm sorry, I knew it was Julie or Megan. So you and Eva, yes, I'll let you, and Julie and Eva, we're going to map out a plan. You could send it to Citrus County, and again, the drop downs hopefully will indicate which program the respondent is talking about. If I remember right, we have it for the program, but not for the county. So if you have I want you guys to get familiar with the survey itself and what they're asking, and then you'll be able to see how you're going to read the information. I think that's a good starting point. I don't want to overwhelm you. That's I would get used to the survey and take it yourself, like you suggested, and then we can go from there with questions. So thank you, Julie and Megan, for what you're doing at Livestream, which is been a very active participant years ago and continuing in the ROSC transformation. Are there any other questions? And when you get a chance, go up into the LSF ROSC landing page and just browse down, and you'll get even more information about all this recovery care. Good stuff we're talking about. I wish everyone a good day, and thank you again for joining us. And when we get the link to the recording of this today, we'll send that out too. Thank you, Rico. everybody, Beth. Good to see all these names, people I know.
Thanks, Brian.
You're welcome. It's good to hear your voice too.
Thank you, Brian.
Thanks, Raj.
Thank you, sir.